Okay, let's dive in. Picture this. Intense, like burning pain in your hands or feet. Pain that's so bad it actually wakes you up at night.
Mm,
And maybe the only relief you get is, dangling your leg or arm off the side of the bed.
right.
Or imagine your fingers and toes changing color, maybe going chalky white or sort of dusky purple, especially when it's cold. This isn't just like everyday poor circulation.
No, definitely not.
We're doing a deep dive today into a really fascinating but often truly devastating vascular disease.
Yeah, it's called Buerger disease. You'll also hear it called Thromboangitis Obliterans, or TAO for short.
DAO.
And the sources we looked at define it as a non-atherosclerotic segmental inflammatory disease. So unlike the usual hardening of the arteries, plaque buildup.
Right, atherosclerosis.
Exactly. This is different. It's an inflammation process, and it mainly targets the small and medium-sized arteries, but also the veins and even the nerves, typically in the arms and legs.
And it's not exactly new, is it? I mean, the sources mentioned observations way back. Von Winter in 1879 talking about spontaneous gangrene.
That's right. But it was really Dr. Leo Buerger back in 1908 who gave us those really detailed descriptions. He studied amputated limbs, which is grim, but
Yeah.
it led to that very descriptive name, Thromboangitis Obliterans, and of course the eponym, Buerger disease.
Got it. And there's one thing the material seems to stress right from the get-go.
Oh, absolutely. It comes up again and again. While we maybe don't know the exact initial trigger, tobacco use, and this is key, in any form is absolutely critical.
Critical for its starting and for how it progresses?
Precisely.
Yeah.
It seems to be the central factor.
Okay, so that link is definitely something we'll keep coming back to. So our mission here is to really unpack the sources, understand this complex condition, like who gets it, what does it actually do inside the body, how do doctors figure it out, and what are the challenges for patients trying to manage it?
Sounds good. Let's start with the who and where, the epidemiology. It's actually kind of hard to pin down the true worldwide incidence.
Why is that?
Well, mostly because data collection just isn't consistent across all countries,
Makes sense. But we do have some estimates, like for North America.
Yeah, the sources give a figure around 8 to 12.6 new cases per 100,000 people each year in North America. But interestingly, they also mention that number seems to be going down over the last few decades there.
Potentially linked to less smoking, maybe.
That's the speculation, yeah. But while it might be declining in North America, the sources point to higher prevalence in places like the Mediterranean, the Middle East, and parts of Asia.
Okay. And there was an important historical point to clear up too, right? About Dr. Buerger's early observations.
Yes, exactly. He initially thought it mainly affected the Jewish population, but that was purely based on who his patients were at Mount Sinai in New York at that time.
Ah, so it wasn't a true global pattern for that ethnicity, just who he happened to see.
Correct. The source material explicitly clarifies a common misinterpretation of an old statistic, something about 80% incidence in Israeli Jews of Ashkenazi ancestry.
Right, I remember seeing that mentioned.
Yeah, the source explains that the original 1965 article actually said 80% of the people in that specific study in Israel were Ashkenazi Jews, which just reflected the local population demographics then. It didn't mean 80% of all Ashkenazi Jews had Buerger disease. A really important nuance to pull out.
That is a crucial distinction. Good clarification from the sources.
Yeah.
Okay, so let's circle back to that dominant factor, tobacco.
It's just unavoidable in the literature.
Yeah.
Cigarette smoking is the biggest risk, definitely. But the sources are clear. Cigars, chewing tobacco, snuff, even marijuana are implicated.
Wow, so pretty much any form.
Seems like it. They even get specific about local tobaccos, like bidis in India or kawang in Indonesia, being linked to higher rates in those areas.
Interesting. And the age it hits is quite striking, too.
Yeah.
Young adults, typically before 40 or 45.
Yeah, the median age mentioned is around 34. That's really young for such a severe vascular issue, much earlier than typical atherosclerosis.
Definitely. And historically, it was mostly men, right? Like, overwhelmingly.
That's what the early reports showed, yeah. Women were maybe only 1 or 2% of cases back then.
But that's changed significantly.
It really has. The sources show later studies reporting women making up, well, anywhere from 23% to over 40% of patients.
And the reason.
The material directly links this shift to the rise in tobacco use among young women during that same time frame. It's another strong piece of evidence pointing right back at tobacco.
Okay, so young adults, more women affected now than before, and this incredibly tight connection to tobacco.
Yeah.
Let's move on to what it actually looks and feels like. Where does it usually strike?
So the sources say it most commonly hits those smaller arteries and veins way out in the extremity. So hands, fingers, feet, toes. That's the classic picture.
But not always just there. Can it show up elsewhere?
Yes, it can. While the limbs are the main site, the material does mention reports of it affecting vessels in the brain, heart, lungs, kidneys, gut, even the aorta and iliac arteries.
Nice.
And they give a specific kind of important example, involvement of the internal mammary artery.
Why is that one so important?
Because surgeons sometimes use that artery for coronary artery bypass grafts, CABG. So the source actually recommends screening Buerger patients for this before planning bypass surgery.
That's a critical point for surgeons, definitely. So
Yeah.
mostly hands and feet, but this potential for wider spread. How does it usually present itself? What are the main symptoms?
The primary presentation is ischemia, lack of blood flow in those distal parts, and that shows up as really severe rest pain.
That pain even when you're not doing anything.
Exactly. Or you get ulcerations, sores that won't heal, and eventually tissue death, gangrene in the fingers or toes.
Just sounds awful. What about claudication, the pain you get with activity?
Yeah, that happens too. But interestingly, the sources often describe it as instep claudication. So pain more in the arch or the front part of the foot rather than the classic calf pain you get with blockages higher up.
Although calf pain can happen later.
It can, yeah, if the disease progresses further up the leg.
Okay. What other signs or symptoms pop up frequently according to the material?
Well, they list a few common ones. Superficial thrombophlebitis, that's inflammation and clotting in a surface vein, seen in about 38% of patients.
Okay.
Raynaud disease, the fingers or toes changing color dramatically with cold, that's seen in 44%. And it can be asymmetrical, like worse on one side, which is a bit of a clue for Buerger.
Interesting.
An abnormal Allen test, which checks blood flow in the hand arteries, is found in 63%. And then just non-specific sensory stuff, like numbness or tingling, in almost 70%.
And does it usually hit both legs or both arms, or is it mixed?
The pattern varies. About half the patients have it just in the lower limbs. Maybe 10% have it only in the upper limbs. And then 30 to 40% have it in both arms and legs. Upper extremity problems are clinically obvious in maybe 40–50% overall.
Right. Now, you mentioned something earlier about surprising connections, like joint pain.
Yeah, this was fascinating in the source material. About 12.5% of patients seem to have rheumatic symptoms, sometimes even before the really bad artery problems start in what they call the pre-occlusive phase.
Before the blockages become severe.
Exactly. They might get these recurring bouts of arthritis, usually non-erosive, often in the wrists or knees, lasting a few days to a couple of weeks.
And this can happen years before.
Get this, the sources say these joint problems can actually precede the Buerger diagnosis by up to 10 years. And often, once the really obvious ischemic signs appear, the joint symptoms just disappear.
Wow. That really hints at something more systemic or inflammatory going on, maybe years before the vessels get critically blocked.
It certainly suggests a more complex process than just, a sudden clot.
Okay, let's dig into that process now. How did the sources describe what's actually happening inside those blood vessels? The pathophysiology.
Well, first off, it's classified as a type of vasculitis inflammation of the vessels. And as we said, it's non-atherosclerotic, and importantly, it's segmental.
Segmental meaning patchy. Not the whole vessel is bad.
Exactly. You find segments of vessel that are clearly diseased right next to segments that look completely normal. And the source describes the disease progressing through 3 distinct phases, histologically speaking: acute, subacute, and late.
Okay, the acute phase sounds like the active, fiery part.
It really is. That's where the main inflammatory action is. And it's key for diagnosis if you can get a biopsy. Though, biopsying an artery in a limb that already has cord blood flow is risky.
Right.
So the source actually suggests that if you find an acutely inflamed superficial vein, that can be a great, much safer source for a biopsy sample.
Good tip. So what do you see in that acute phase?
You see intense inflammation involving all layers of the vessel wall. And the lumen, the channel where blood flows, gets completely blocked by this very specific, highly cellular thrombus or clot.
Not just a regular blood clot.
No, it's unique. It's packed with inflammatory cells, mostly lymphocytes, actually outnumbering neutrophils. And it has these characteristic little pockets of neutrophils called microabscesses within the clot itself.
Microabscesses inside the clot. Okay. What happens next in the subacute phase?
As it moves into the subacute phase, the source says recanalization starts. Tiny new channels begin to form through the clot. The overall cellularity goes down, and those microabscesses vanish.
And the late phase.
In the late phase, you're left with a more organized, recanalized clot inside fibrotic, scarred vessel walls.
Now, what's the absolute key thing that makes this look different under the microscope compared to, say, atherosclerosis or other types of vasculitis?
This is super important, and the sources really emphasize it. In all phases of Buerger disease, acute, subacute, late, the basic structure, the architecture of the vessel wall itself, including a layer called the internal elastic membrane, stays intact.
It doesn't get destroyed.
No, there's no necrosis, no actual destruction of the vessel wall tissue. This is a major distinction from atherosclerosis, where plaque actively damages the wall, and from some other vasculitides that actually cause the wall to die off, to necrose.
So the wall holds together, but the inside is blocked by this intense, specific inflammatory clot. That's the core problem. Which brings us back to the million-dollar question, why? Why does this happen? What triggers it?
And here we are again. The sources state pretty clearly the definitive cause is still unknown. But that association with tobacco exposure is just overwhelmingly strong. It's the most significant factor identified.
Seems like the elephant in the room for this disease.
It really is. The correlation is stark. Active tobacco use is tied to onset. It's tied to progression. Stopping tobacco use leads to remission.
And starting again.
Starting again is strongly linked to recurrence, flare-ups, and a much higher risk of needing amputations. There seems to be a dose effect, too.
Like, how much you smoke matters.
Yeah. Most patients described in the studies use 20-40 cigarettes a day. But the source warns that even lower levels, maybe just 4 to 8 cigarettes a few times a week, can trigger problems. And remember, it's all forms: cigarettes, cigars, pipes, chew, snuff, marijuana.
Any word on secondhand smoke?
The effect isn't definitively proven from the material provided, but it suggests it might play a role in keeping the disease active. It's something to consider.
Okay, so tobacco is front and center. Are there any other potential contributing factors the sources mention, things researchers are looking into?
Yes, they do touch on other lines of investigation. One big area is autoimmune pathogenesis.
Meaning the body's immune system attacking itself.
Potentially, yes. Studies have looked into things like maybe an increased sensitivity of immune cells to components like collagen or even glycoproteins found in tobacco.
Ah, so tobacco might trigger an immune reaction.
That's one theory. Others include finding elevated levels of antibodies that target the endothelial cells lining the blood vessels, problems with how the vessels relax, deposits of immune proteins in the vessel walls, and infiltration by specific types of immune cells. So yeah, an autoimmune angle is definitely being explored.
What else? Genetics?
Genetics is mentioned too. Some studies found associations with specific HLA types. Those are like immune system identifiers, specifically HLA-AP9 and HLA-B5, and also a polymorphism in a gene called MICA.
So maybe a genetic predisposition makes some people more susceptible when exposed to tobacco?
Possibly. And then there's that intriguing potential link to infection we touched on earlier.
Right, the periodontal disease connection.
Exactly. The sources discuss this possible link between Buerger's and severe gum disease or other oral bacterial infections. They specifically cite a study that found DNA from bacteria commonly found in the mouth inside the blocked arteries of Buerger patients who also had significant periodontitis.
But not in control patients.
Correct. They didn't find that bacterial DNA in arterial samples from control subjects. It's a fascinating lead, the idea that maybe bacteria from chronic gum infections could somehow, perhaps interacting with tobacco exposure in susceptible people, trigger this specific type of vascular inflammation.
That's really interesting. Okay, so you've got this complex picture. Young smoker, specific symptoms, maybe some odd joint pain history, this unique vessel inflammation. And you absolutely have to rule out a whole bunch of other stuff. How do doctors actually arrive at a diagnosis of Buerger disease?
Well, the sources emphasize it's primarily a clinical diagnosis. It's about recognizing that pattern of signs and symptoms, applying specific criteria, and crucially, excluding everything else it could be.
Okay, let's walk through the major criteria listed in the source material.
All right. First, onset of those distal limb ischemia symptoms, problems with blood flow in hands or feet before the age of 45.
Young onset, check.
Second, a history of tobacco abuse. That's pretty much non-negotiable.
Tobacco use, check.
Third, and this is absolutely critical, the exclusion of other potential causes. We're talking atherosclerosis, autoimmune diseases like lupus or scleroderma, hypercoagulable states where your blood clots too easily, diabetes, high lipids, high blood pressure, kidney failure. The list is long. You have to actively test for and rule all these out.
So a huge part of diagnosing Buerger's is confirming what it isn't.
You got it. Fourth criterion. Evidence that the larger arteries proximal to the disease, like the popliteal artery behind the knee or the brachial artery in the upper arm, are relatively normal, undiseased. The problem is mainly downstream.
Focus on the smaller distal vessels. Check.
And fifth, objective documentation that there is occlusive disease distally. This needs to be shown with tests like histopathology from a biopsy or vascular lab studies like Doppler or plethysmography, or often considered the gold standard, invasive contrast arteriography.
What about newer imaging, like CT or MR angiography?
The sources mention them as promising, but note they might not yet be sensitive enough to reliably pick up the very specific small vessel pathology that's characteristic of Buerger's. They're useful for ruling out proximal problems, though.
Okay. And there were minor criteria, too. Things that support the diagnosis but aren't essential.
Yeah, things like having that migratory superficial phlebitis, having Raynaud disease, especially if it's asymmetric, having involvement in the arms, and that specific instep claudication we talked about.
Got it. So what tests are actually run, both to get that objective proof and to do all that excluding?
Okay, labs first. The sources are very clear. There is no specific blood test that says, yes, this is Buerger disease. Lab results are usually normal.
So why do them?
Primarily for that exclusion purpose. You run tests to rule out autoimmune conditions, checking things like ANA, ESR, rheumatoid factor. You check for clotting disorders, protein C, protein S, PT, PTT, antiphospholipid antibodies. You check for diabetes, kidney function, lipids, the works.
Just ticking boxes to make sure it's not something else.
Pretty much. Sometimes general inflammation markers like ESR or fibrinogen or the platelet count might be a bit elevated if there's an active ulcer or bad infection, but that doesn't point specifically to Buerger's. They also mentioned that finding things like anticardiolipin antibodies or a specific prothrombin gene mutation might indicate an increased risk of clotting in general, but they don't diagnose Buerger's itself.
Okay, so labs are mostly for ruling things out. What about imaging and other tests?
Non-invasive vascular lab studies are really important. Things like the ankle brachial index, ABI, taking blood pressures at different segments down the limb, and maybe transcutaneous oximetry, TCPO2, to measure tissue oxygen levels.
Assessing how bad the blood flow actually is.
Exactly. An echocardiogram or ultrasound of major vessels might be done to look for potential sources of emboli, clots traveling from the heart, or maybe an aneurysm somewhere else. CTA and MRA, as we said, help look at the bigger picture proximally, rule out emboli sources, define anatomy, but might miss the fine details distally.
And the test considered most definitive according to the sources.
That would be invasive arteriography, where they inject contrast dye directly into the arteries and take x-rays.
What does that show in Buerger's?
It shows a very characteristic pattern. Multiple bilateral meaning on both sides, blockages, occlusions, or narrowing, stenoses, that are segmental, affecting the distal arteries in the hands and feet. Crucially, the arteries proximal to these blockages look normal.
Okay.
The blockages themselves often look abrupt or they taper sharply, and you typically see lots of distinctive collateral vessels, tiny, new, often corkscrew-shaped or spider-like vessels that have formed to try and get blood around the blockages.
The tree root or corkscrew collaterals.
Exactly. And another really key finding on arteriography is the absence of calcification or atheroma, the typical signs of atherosclerosis. Arteriography can also sometimes reveal disease in limbs that don't have symptoms yet, and very occasionally might identify a vessel suitable for bypass, though that's rare. Oh, and transesophageal echo, TEE, can also be used to get a really good look at the heart and aorta to rule out emboli sources.
Right, so it's this whole picture. Young smoker, distal symptoms, rule out everything else, then see that classic pattern on arteriography. Once the diagnosis is made, what comes next? What are the treatments and what are the really tough challenges here?
Well, this brings us right back to the most critical point hammered home in all the source material, the absolute, undeniable cornerstone of therapy.
Let me guess. Stop smoking.
Completely. Total, permanent abstinence from all forms of tobacco. There's even a quote in the source that says it all. Except for discontinuation of tobacco use, there is no other definitive therapy.
Wow, that definitive.
It really is.
So-
The sources state clearly, stopping tobacco is essential for success at any stage. It's the main thing that determines the prognosis, the main thing that influences whether or not someone ends up needing an amputation.
Are there stats on that?
Yeah, one study cited found that 94% of patients who managed to permanently quit tobacco avoided amputation. Compare that to only 43% of those who kept smoking.
That is incredibly stark. It basically says quitting saves limbs, continuing smoking often leads to losing them.
That's the message, loud and clear. And it means everything. No cigarettes, cigars, pipes, chew, snuff, marijuana. The sources even caution against using standard nicotine replacement therapy like patches or gum.
Why? Because of the nicotine itself.
Possibly. The concern is that nicotine itself might still contribute to the disease process, the vasoconstriction or inflammation. So they tend to recommend non-nicotine medications to help quit, like bupropion or varenicline.
Okay, and monitoring cessation.
Yeah, things like urine tests for nicotine or cotinine are mentioned, sometimes even inpatient treatment programs for people who are really struggling to quit. And again, that potential role of secondhand smoke exposure is mentioned as something to avoid.
Okay, quitting is job number one, absolutely essential. Beyond that, what else can be done medically?
Well, other efforts focus on trying to improve blood flow and manage the symptoms. This includes trying to avoid things that cause vasoconstriction and maybe encourage vasodilation. Though, honestly, the sources say the effectiveness of standard vasodilator drugs like calcium channel blockers or alpha blockers isn't really proven specifically for Buerger's.
What else?
Antiplatelet drugs, like aspirin, are often used. Sometimes short-term heparinization during acute flare-ups, or even attempts at thrombolysis, clot-busting drugs have had some anecdotal success reported, but it's not standard. Other things mentioned are spinal cord stimulation, which can sometimes help with pain, and using intermittent pneumatic compression IPC devices on the limbs.
Like those inflatable sleeves.
Yeah, to help circulation. Then there are the prostacyclin derivatives.
Like Reloprost.
Exactly. Iloprost is highlighted. Studies mentioned in the source showed it had some promising results when given intravenously, especially compared to just aspirin or even a surgical procedure called lumbar sympathectomy. It seemed to help with healing ulcers, significantly relieving rest pain, and reducing the need for amputation.
So that's a potentially useful medical therapy.
It seems promising, yeah, though the sources still say more studies are needed to confirm its place.
Are there any newer, maybe more cutting-edge therapies being looked at?
Yes, the sources discuss gene therapy and cell therapy as potential future options, although they're still largely developmental.
Gene therapy. Like changing genes.
More like adding a gene. One approach involves injecting a gene for vascular endothelial growth factor, or VEGF.
VEGF. That stimulates blood vessel growth.
Precisely. The idea is to try and encourage the body to grow new blood vessels, or angiogenesis, in the ischemic limb, improving blood flow, developing more collaterals, and hopefully helping ulcers heal.
And cell therapy.
That usually involves taking certain cells, often from the patient's own bone marrow, specifically mononuclear cells, which include stem and progenitor cells, and injecting those directly into the affected limb.
Same goal. To grow new vessels.
Pretty much the same goal. Promote angiogenesis, improve blood flow, reduce symptoms, heal ulcers. And some studies cited in the material have shown some really encouraging amputation-free survival rates in patients treated this way compared to controls.
That sounds potentially game-changing.
It could be. The study showed it's feasible and generally safe in the short term, however. The sources are careful to point out that there have also been reports of potential long-term adverse events in some experimental groups, including, worryingly, some sudden deaths.
Oh.
Yeah, so the conclusion is clear. While these therapies are promising, we absolutely need larger, well-designed, randomized controlled trials to really figure out if they're truly effective and safe in the long run, either used alone or maybe combined with other treatments. So exciting, but still very much in the research phase.
Okay. What about just managing the day-to-day problems like infections or wounds?
That's obviously a huge part of care. Any infection or cellulitis needs aggressive treatment with antibiotics, sometimes drainage or debridement. If that superficial thrombophlebitis flares up, NSAIDs often help. Wound care itself is critical. Meticulous cleaning, removing dead tissue, using appropriate dressings, maybe using IPC to help healing.
And pain. We mentioned it's often severe.
Managing the pain is a massive challenge. It often requires strong opioid narcotics. Sometimes prolonged epidural analgesia, like women get during childbirth, might be used for severe rest pain.
Given that the disease is so far down in the small vessels, Are surgical options to restore blood flow limited?
Very limited, unfortunately. Amputation is sadly often necessary. It might be needed for unbearable rest pain that can't be controlled, or for severe infection that's spreading, or just when tissue is clearly dead and unsalvageable.
And the impact of amputation is profound. There was that statistic.
Yeah, it's truly sobering. The source stated that 85% of Buerger patients who underwent a major amputation ended up losing their jobs.
85%. That just underscores the devastating life-altering consequences beyond the physical loss.
Absolutely. What about other surgeries? Sympathectomy.
That's sometimes done cutting the sympathetic nerves that normally cause vasoconstriction. It's performed in maybe 20% of patients. The hope is it might relieve milder pain or coolness, or maybe help marginal ulcers heal by increasing skin blood flow. But again, the sources say its actual effectiveness isn't really proven, though it rarely seems to make the ischemia worse. And bypass surgery, trying to route blood around the blockages.
That's usually very difficult in Buerger's. The source estimates less than 10% of patients are even suitable candidates.
Why so few?
Because the disease is typically so extensive in those very small distal arteries in the thigh or hand, there's often just no decent target vessel down there to sew a bypass graft onto.
And even if you can do a bypass.
The results aren't great compared to bypasses for atherosclerosis. Graft patency rates, how long the bypass stays open, are significantly lower, and they're almost 50% lower again if the patient keeps smoking.
Wow. Another hit from smoking.
Plus, the veins they might use for the graft are often in poor condition because of previous bouts of phlebitis. So yeah, bypass is rarely a good long-term fix.
There was one other surgical technique mentioned, omental transfer.
Right. The sources mention that as an option, usually for severe rest pain or ulcers that just won't heal. It involves surgically moving a piece of the omentum, that's a fatty tissue from the abdomen, with really rich blood supply and laying it onto the ischemic area in the limb.
Trying to bring a new blood supply to the area.
Exactly. The hope is it increases skin temperature, reduces pain, and helps ulcers heal by providing that collateral circulation.
It definitely sounds like a condition that demands constant vigilance from the patient. What are the key things patients need to know about living with Buerger disease?
Well, number 1, 2, and 3 is education about that absolute need for tobacco abstinence. Avoiding all tobacco and potentially secondhand smoke, too. Hammering home that direct link between continued use and disease progression and the very real risk of losing limbs.
And just practical day-to-day care.
Yeah, home care is vital. Protecting the hands and feet from any trauma, even minor bumps or scrapes. Protecting them from cold exposure. Avoiding harsh chemicals.
Meticulous hygiene.
Absolutely. Daily inspection of feet and hands, careful nail care, wearing proper, well-fitting shoes that don't rub or cause pressure points. And if any skin breakdown or wound does occur, really diligent wound care practices are essential. It's constant awareness and care for those vulnerable limbs.
And if amputation does become necessary?
Then the focus shifts to post-amputation rehab physical therapy, learning to use a prosthesis if applicable, proper care of the residual limb, and also addressing the significant psychological aspects with body image changes, working towards functional independence. And as we keep saying, managing chronic pain often remains a huge ongoing battle for these patients.
Okay, we've covered a massive amount of ground here, the history, the pathology, the diagnosis, the really tough treatment landscape. Let's try and tie it all together now by walking through the case study that was provided in the source material. It seems to illustrate so many of these points.
Yeah, it's a powerful example. It describes an 18-year-old male, a smoker.
18.
So young.
Exactly. His initial problem was an ulcer on his left big toe that just wouldn't heal. It had been there for 6 months after some minor injury. He also had pain in his foot when he exercised that instep claudication we talked about, and severe pain in his toes at night, which got better only when he dangled his leg over the side of the bed.
Classic rest pain relief posture. Did he have the hand symptoms too?
He did. He reported symptoms in both hands, feeling cool, changing color, burning, tingling in all his fingers when exposed to cold. Classic Raynaud's type phenomenon, which got better when he warmed them up. And his symptoms were worse in winter.
So, young guy, smoker, distal ischemia, foot ulcer, instep claudication, rest pain, Raynaud's. I mean, that sounds like the textbook Buerger's profile right there.
It really does. How did they confirm the diagnosis in his case?
Well, the physical exam showed what you'd expect. Pulses in his feet were weak or absent. He had an abnormal Allen test in his hands. He had those skin changes like redness when the foot was down, pallor when it was elevated. Okay.
And crucially, they ran that whole battery of lab tests to rule out everything else. Autoimmune markers, clotting factors, diabetes tests, and everything came back negative. So the labs did their job of exclusion, confirming it wasn't lupus or a clotting disorder or something else mimicking Buerger's. What about the imaging?
They did bilateral arteriography, both arms and legs, and the findings were described as diagnostic and consistent with Buerger disease. Multiple blockages and narrowings way down in the distal arteries of his hands and feet, radial, ulnar, tibial arteries, but the larger arteries higher up looked normal.
That classic pattern again.
Exactly. And vascular lab studies also confirmed he had severe ischemia distally. So the clinical picture, ruling out other causes, and that characteristic arteriogram all pointed strongly to Buerger's.
So what did they try treatment-wise first?
Initially, they went conservative. Really careful local wound care for the toe ulcer, importantly. Avoiding things like foot soaks, which can actually make things worse in these patients. They tried a circulator boot therapy for a while, then sent him home with an intermittent pneumatic compression device and specific wound dressings. They held off on surgery initially.
Hoping maybe quitting smoking would be enough.
That was the hope. The case notes he had actually quit smoking about 5 weeks before he first came in.
Okay.
However, a few months later, his local doctor reported the ulcer got much worse after he stopped using the IPC machine and he had started smoking again.
Ugh, there it is. That direct link playing out right in front of them. He starts smoking, things immediately get worse.
It's stark, isn't it? So he came back, having quit again, but the ulcer was much bigger. Eventually, they did attempt surgery, a left femoral popliteal bypass graft, combined with amputating the left great toe.
So they did manage to find a target for a bypass.
Apparently so in his case. And the source notes that initially the bypass worked well. He had almost complete wound healing during the period when he remained tobacco-free.
Okay, so proof of concept bypass plus quitting worked. But I have a bad feeling about where this is going.
Yeah. Sadly, within 6 months of that surgery, he had started smoking again.
Man.
And just as the sources predict, the bypass graft clotted off, thrombosed, which led directly to him needing a below-knee amputation on that left leg.
Oh, man. It's just devastatingly predictable based on everything we've discussed. The bypass worked when he quit, failed when he smoked.
Exactly. And the case goes on to describe how, despite multiple further attempts to help him quit permanently, he just couldn't stay off tobacco. And the disease just kept marching on relentlessly. He lost one leg, and then the other leg became threatened.
He developed acute ischemia in the right foot, too.
Yeah, severe enough to need hospitalization. Even though he'd apparently been off cigarettes for about 4 weeks that time, the underlying damage was too extensive. Imaging showed severe blockages that made any further bypass attempts impossible. They even tried thrombolysis, clot-busting drugs, but that didn't work either.
And the case study also highlighted the non-physical toll, didn't it?
It really did. It mentioned that during one evaluation, he was exhibiting really difficult behavior, being verbally abusive. This led to a psychiatric consult. He was diagnosed with major depressive disorder, which the psychiatrist felt was directly related to his overwhelming medical problems. He had insomnia, anhedonia, couldn't feel pleasure, and even passive suicidal thoughts. It just paints such a vivid picture of the incredible burden, the constant pain, the disfigurement, the loss of function, all compounded by the psychological weight and the struggle with addiction.
Absolutely. And the conclusion of the case, based on the source.
After all attempts at revascularization failed, and his ischemia just kept getting worse despite maximum pain management, the plan was made for him to undergo amputation of his other lower extremity as well.
Just tragic. But a really powerful illustration of how aggressive this disease can be, especially when tobacco use continues. It really brings all the pieces together.
It does.
Okay, let's try to quickly summarize the absolute key takeaways from this deep dive into the source material on Buerger disease.
Yeah, right. First, remember it's an inflammatory disease, not atherosclerotic plaque. It hits the small and medium-sized vessels, mostly out in the hands and feet.
Second, that link to tobacco use any kind is absolutely central. It drives the onset, the progression, and quitting is the key to remission.
Third, it typically hits young adults, often before they're 45.
Fourth, diagnosis is clinical. The right picture in a smoker, plus rigorously ruling out a lot of other conditions, often confirmed by that specific pattern on arteriography.
Fifth, treatment cornerstone, absolute, complete tobacco cessation. It's the single biggest factor influencing whether someone keeps their limbs.
Sixth, the main symptoms you see are things like superficial vein inflammation, thrombophlebitis pain, that awful rest pain, instep claudication, ulcers, gangrene, and Raynaud's phenomena.
And seventh, while surgery is often limited and amputation is unfortunately common, There are promising future therapies like gene and cell therapy being researched, aiming to stimulate new blood vessel growth. But they need more validation.
Right. We've definitely gone deep today into Buerger disease, covering its history, how it works, who it affects, how it's diagnosed, and the really, really challenging path to managing it.
And just to say it one more time, because the sources repeat it constantly, if there's one message to take away, it's that for anyone diagnosed with Buerger's, stopping all tobacco completely and forever isn't just a good idea. It's the absolute foundation of any possible treatment and the main thing that dictates their future, especially regarding amputation risk.
It is the unavoidable truth that comes through loud and clear from the material. And maybe that leaves us with a final thought, something provocative for you, the listener, to consider. We see this incredibly clear, devastating connection between tobacco use and this limb-threatening disease. We see the immense difficulty patients, like the young man in the case study, have in quitting, even when facing such dire consequences. What does this really tell us about the incredibly complex interplay of addiction, chronic disease, personal behavior, and medical outcomes? It really raises profound questions, doesn't it, about the kind of comprehensive, multifaceted support people need when dealing with conditions so tightly interwoven with lifestyle factors and addiction.